Most people planning to have a baby think about the cost of diapers, the cost of a stroller, and whether they can afford childcare. Those are real costs. They are also the smallest part of the picture. The full financial cost of having a child in the United States when you count what the system charges you at the hospital, what it takes from your paycheck during leave, what it costs to keep your career intact, and what you will spend on childcare before your child reaches kindergarten is so far above what any mainstream source discusses that most families only understand it after they have already absorbed it. Here is every number they do not put in the parenting books. Here is what most people planning a pregnancy budget for. The hospital bill, which they assume insurance will mostly cover. Some time off work, which they assume will be manageable. Baby gear, which they research extensively. Childcare, which they know will be expensive, but assume they can handle once they see the actual numbers. That is the conventional mental model for the cost of having a baby. It is technically accurate for about 20% of the real cost. Life good. Here is the rest of it. The Affordable Care Act requires insurance plans to cover maternity care. That sentence is technically true and practically misleading. Coverage is not the same as cost. A fully insured delivery at an in-network hospital with no complications can still generate an out-of-pocket bill of $3,000 to $10,000, depending on your deductible, the timing of your delivery relative to the calendar year, and whether every provider in the room was actually in your network. The ACA mandate covers the category. It does not cap what you pay. And the hospital bill is not where the real money goes. It is just where the surprise starts. Here is the full cost stack that does not appear in any single disclosure you will receive before you are already in it. Start with the delivery bill. The average cost of a vaginal delivery in the United States is approximately $14,000 before insurance. A cesarean section averages approximately $26,000. After insurance, the average out-of-pocket cost for a vaginal delivery is approximately $2,800. For a C-section, it is approximately $3,200. If your delivery crosses a calendar year boundary, meaning you are admitted in December and deliver in January, your deductible resets. You pay it twice. On a plan with a $3,000 individual deductible, that is $6,000 in deductibles alone for a single delivery. No one tells you this when you schedule your due date. Then come the bills you did not know were coming. The No Surprises Act of 2022 was designed to end out-of-network billing at in-network facilities. It has a documented gap. Anesthesiologists, neonatologists, and assistant surgeons who work at in-network hospitals frequently operate as independently contracted providers who are not in your network. The law requires them to charge in-network rates only in specific circumstances. A 2023 KFF Health System Tracker analysis found that surprise medical bills at delivery remain common despite the legislation, with anesthesiology being the most frequent source. The bill arrives 6 to 12 weeks after delivery. You are sleep deprived, you have a newborn, and you owe money you had no way to predict. Now add unpaid leave. The Family and Medical Leave Act guarantees 12 weeks of unpaid job-protected leave for eligible employees. Eligible means you work for an employer with 50 or more employees and have worked there for at least 12 months. Approximately 40% of US workers do not qualify. For those who do qualify, 12 weeks unpaid on a $70,000 annual salary is $16,154 in lost income. The United States is the only high-income country in the world with no federal paid parental leave guarantee. Every other G7 nation has one. The absence is a policy choice, not an oversight. Now add childcare. The national average cost of infant daycare in the United States is approximately $1,200 per month. In major metros including New York, San Francisco, Washington, D.C., and Boston, the average exceeds $2,000 to $3,500 per month. Annual infant care costs in these cities range from $24,000 to $42,000 per year. The Dependent Care Flexible Spending Account, the primary federal tax benefit for childcare, has a contribution cap of $5,000 per year. That cap has not been updated since 1986. Had it kept pace with childcare cost inflation, it would be approximately $18,000 today. It covers roughly 4 months of average infant care nationally and less than 2 months in high-cost markets. Now add the cost that nobody frames as a cost of having a child. The motherhood penalty. Economists Claudia Goldin, Marianne Bertrand, and Lawrence Katz have documented across multiple studies that mothers earn approximately 5% less per child than childless women with identical qualifications, experience, and hours worked. Fathers earn more after having children. The penalty is not explained by time out of the workforce. It is explained by the way employers price flexibility. Women who take leave, reduce hours, or signal caregiving responsibility are penalized in pay and promotion, at a rate that compounds over a career. Over a 20-year period, the cumulative earnings gap for a college-educated professional woman with 2 children relative to a childless peer averages over $200,000 in lost wages and retirement contributions. That number is the largest single cost of having a child in the United States. It appears in no budget spreadsheet and no parenting book. There are several specific cost mechanisms that each operate differently and each go undisclosed in the standard conversation about the cost of having a baby. The deductible timing trap. Health insurance deductibles reset on January 1. Babies do not schedule themselves around your deductible. If your prenatal care begins in October and your delivery is in January, you pay your deductible twice for a single pregnancy. On a family plan with a $6,000 deductible, that is $12,000 in deductibles across 2 calendar years for 1 pregnancy. Fertility clinics and OB practices are aware of this. It is not discussed at the first appointment. Surprise billing at delivery. The No Surprises Act of 2022 created new protections against out-of-network billing in emergency situations. It has a specific and documented gap for non-emergency services at in-network facilities. An anesthesiologist who administers your epidural, a neonatologist who evaluates your newborn, and a specialist called in during a complication are all potentially out-of-network, even in an in-network hospital. The law requires advance notice for non-emergency out-of-network care, but the notice requirement is not always followed and is not enforceable in real time when you are in active labor. The bill comes later. The FMLA eligibility gap. The Family and Medical Leave Act covers approximately 60% of the US workforce. The 40% not covered includes workers at small businesses, workers who have not been with their employer for 12 months, and part-time workers below the hour threshold. For uncovered workers, there is no guaranteed job protection during leave. Some states have enacted their own paid leave programs, including California, New York, New Jersey, Massachusetts, Connecticut, Oregon, Colorado, Washington, and Maryland. In the remaining states, an uncovered worker who takes extended leave after birth has no federal job protection and may have no income replacement. The childcare cliff. Infant care, meaning care for children under 12 months, is the most expensive category of childcare. It is also the category families need immediately when parental leave ends. The cost drops as children age and can access preschool and pre-K programs, some of which are subsidized. But the first year, which coincides with the period of greatest financial stress from delivery costs and lost leave income, is the most expensive year of childcare in a child's life. The Child Care and Development Fund provides federal subsidies for low-income families. Middle-income families earning above the eligibility threshold but below the level where full costs are manageable receive no subsidy and face the full market rate. The motherhood penalty compounding. The 5% per child wage penalty does not stay at 5%. It compounds because wages are the base on which promotions, bonuses, and retirement contributions are calculated. A woman earning $80,000 who absorbs a 5% penalty after her first child earns $76,000. Her bonus, her 401k match, and her Social Security calculation are all based on $76,000. If she has a second child and absorbs another 5% penalty, she earns $72,200. Her retirement savings gap relative to a childless peer widens every year. The gap is documented, peer-reviewed, and almost never discussed in the context of family financial planning. What could possibly go wrong? Here is what these costs look like when they land simultaneously on a real household. A dual-income couple in a major metro. Combined income $140,000. They have planned carefully. They have a $10,000 emergency fund. They have read the parenting budgets. Here is what actually happens in year 1. Delivery out-of-pocket costs $3,200. Surprise anesthesiology bill arrives 8 weeks later, $1,400. 12 weeks unpaid leave for one partner on a $70,000 salary, $16,154 in lost income. Infant daycare beginning at week 13, $1,800 per month, $21,600 for the remainder of the year. Dependent care FSA, offset, $5,000. Net childcare cost after FSA, $16,600. Baby gear and setup costs, $3,000 to $5,000. Total year 1 financial impact beyond normal living expenses, approximately $40,000 to $42,000. Their $10,000 emergency fund is gone in the first 3 months. The rest is absorbed through reduced retirement contributions, credit card debt, or family support. None of this was in the parenting budget they found online, and none of it accounts for the motherhood penalty that began accruing the day one partner went on leave and was passed over for a project, a promotion, or a client relationship that went to someone without competing caregiving demands. The United States has the highest maternal mortality rate of any high-income country. It also has the only paid leave gap among G7 nations, the highest out-of-pocket delivery costs, and the least regulated childcare market. These are not coincidences. They are the output of a system that has consistently treated the cost of reproduction as a private financial problem rather than a social infrastructure question. Yes, this is real. In 2023, the Peterson KFF Health System Tracker published an analysis of delivery costs and out-of-pocket spending in the United States. The analysis found that the average out-of-pocket cost for a vaginal delivery was $2,054, and for a cesarean section was $3,214 after insurance. It also found that costs varied dramatically by state, insurer, and facility, with some families paying over $10,000 out of pocket for uncomplicated deliveries. In 2023, the same organization published a separate analysis finding that the United States spends more on maternity care per birth than any other high-income country and achieves worse outcomes on maternal and infant mortality. The US maternal mortality rate is approximately 23 deaths per 100,000 live births. The UK rate is 9, Germany is 3, Norway is 2. The gap in outcomes exists despite the gap in spending, because the spending in the US is concentrated in acute hospital care and not in prenatal support, paid leave, or postpartum follow-up. The motherhood penalty was most comprehensively documented by economist Claudia Goldin, who received the Nobel Prize in Economics in 2023, in part for her work on gender earnings gaps. Her research, published across multiple decades, established that the majority of the gender wage gap is not explained by occupation, education, or experience. It is explained by the penalty attached to flexibility and caregiving, which falls disproportionately on mothers. The penalty is not illegal, it is structural. If you are planning a pregnancy or have recently had a child, here is what the cost structure means in practice and what you can actually do about it. 1. Time your delivery to stay within 1 calendar year if possible. If your due date is in December or January, talk to your OB about your insurance deductible situation. Staying within a single calendar year means you pay 1 deductible, not 2. This is not always controllable, but it is worth understanding before it happens. 2. Request a list of all providers who will be present at your delivery and verify their network status before you go into labor. Ask your hospital's patient financial services department to identify the network status of the anesthesiology group, the neonatology group, and any other contracted services used at delivery. Get it in writing. If any provider is out of network, ask the hospital to substitute an in-network provider or get a prior authorization in writing, committing to in-network rates. This conversation is awkward. It is less awkward than a $3,000 surprise bill 8 weeks postpartum. 3. Maximize your dependent care FSA before your child is born. The $5,000 cap is inadequate, but it is real money. Enroll during your employer's open enrollment period before the birth year. The funds are available from the first day of the plan year, even if you have not yet contributed the full amount. 4. Understand your FMLA eligibility and your state's leave laws before you need them. If you work for an employer with fewer than 50 employees, you may have no federal job protection during leave. Check your state's paid family leave program. 9 states plus DC currently have operational paid leave programs. If you are planning a pregnancy and have flexibility in your employment, this is worth factoring into job decisions before you conceive. 5. Build a delivery emergency fund separately from your general emergency fund. Target $5,000 to $10,000 specifically for delivery and the first 3 months of postpartum expenses. Your general emergency fund will be needed for its intended purpose during this period. Conflating the two leaves you without a buffer when you are least equipped to manage a financial surprise. 6. Model the motherhood penalty before you decide on leave and return to work timing. This is an uncomfortable calculation, but it is a real one. For professional women, the combination of time out of the workforce, reduced hours, and the implicit penalty for caregiving visibility can have a larger long-term financial impact than any other decision made in the year of a child's birth. Understanding the numbers does not tell you what decision to make. It tells you what you are actually choosing between. This is not financial advice. Please do not sue us. If this reached someone who is planning a pregnancy and had no idea these costs were coming, share it. The system was not designed to tell you. The channel grows when the right people find it at the right time.